Attendees are in listen-only mode.
Hello, everybody that is joining us today for the TVN webinar series. Today's webinar is on rehabilitation for the frail elderly, models of care and quality indicators. This is these are the final results of a TVN knowledge synthesis grant. Our presenter today will be Donna Ouchterlony from St. Michael's Hospital. But before we get to the webinar, I just want to give a bit of background and a bit of an update on TVN. So the TVN webinar series is a regular forum where Canadian and international experts share research and insights on advancements in assessing and caring for frail elderly Canadians. Over the past couple of months, we've been highlighting the outcomes of TVN-funded knowledge synthesis grants, and today's presentation is no exception. Be on the lookout for in the next couple of months where we will continue on the TVN webinar series, and it's going to be used once this series on knowledge synthesis grants is over. It will be used to highlight the results of TVN-funded research going forward. But before we get to the actual webinar, I just want to highlight some of the things that are going on that you may be interested. We have two research calls that are open right now. The first one is the 2015 Catalyst grants, which were launched last week. These are one-year grants. The pre-application notice of intent to apply is due October 5th of 2015, so upcoming, and the full application is due November 9th of 2015. We have transformative research grant projects or call that has been open since June of last year. The pre-application notice of intent to apply is coming up on October 1st, and the full application is due Tuesday, December 1st. Full details of these research calls are available on our websites, and we encourage everybody who is eligible to apply. Our call for new one-year fellowships was launched this week. This is revamps our fellowship program into a one-year opportunity. Please visit our website for further details. And upcoming at the end of September is our third annual TVN Conference, which is dedicated to improving care for frail elderly Canadians. That's due September. That's going to occur September 27th to the 29th in Toronto at the Sheraton Centre. The link to register for the conference is on our website. It's proven to be a very interesting forum, and this year we expect somewhere around 400 attendees. So it's grown organically every year, and each year we have international experts plus Canadian experts presenting either state-of-the-art lectures or results of TVN funded research. And finally, our last update is that we have a TVN Frailty Workshop at the Canadian Hospice and Palliative Care Association Conference in Ottawa on October 29th, and this looks at frailty measurement as an impetus or as a gateway to advanced care planning. A variety of experts from across Canada will be speaking at our conference workshop. Please register for the workshop and in the annual conference. It is quite an interesting and useful conference. But without further ado, I'd like to get on to why you've tuned in, and this is our webinar, which looks at quality of life measures for frail, elderly, traumatic brain injury survivors, which is and a systematic review. And our presented, as I've said before, is Donna Ouchterlony from St. Michael's Hospital. She's the medical director of the Head Injury Clinic. She's the founder of the first neuro-rehabilitation clinic in Canada and co-founder of Sunnybrook and Women's College Health Sciences Center Head Injury Clinic, faculty member of the Department of Family and Community Medicine and Department of Medicine, Medicine Division of Physical Medicine and Rehabilitation at the University of Toronto, and her research focuses on improving patient care for individuals experiencing traumatic head injury or traumatic brain injury, which is common in frail older adults. So without further ado, I will turn it over to Donna, but just one other housekeeping issue is that we'd like to answer as many questions as possible during the for this webinar, and if you could type in your questions using the chat function on the webinar, we will collate them, we will group similar questions and answer all of them and answer as many as we can get to at the end of the presentation. So please submit as many questions as possible. If we don't get to all the questions, we can always answer them offline after the presentation. So without further ado, I'm going to turn it over to Donna.
Thank you very much, John. We're delighted to be part of TVN. I think this is a great organization. I have with me today also presenting Dr. Cindy Hunt, who's our head of research in the head injury clinic and has done much of this work. So she's very knowledgeable in this area, and both of us are delighted to be here. So I'll start my slides. I'd like to start my slide. Just a second. Does this seem to have a slight problem here? No, I do not. Sorry. Okay. It's oh, there we are. So we had a large team working on this, and here are some of the members of our team, including a knowledge user, a patient, and that was extremely helpful. So elders and traumatic brain injury, where is the research gap? And we really didn't know ourselves until we got this wonderful grant and started to look at this. So we started with a literature review, like what's out there, what have people been doing? And of course we use the PRISMA guidelines. We're going to present to you our results and then our conclusions. So elders at risk for traumatic brain injury, TBI is a highly heterogeneous etiology in the elderly, also in severity, pathology, and in clinical course. I mean, if we look at the etiology of TBI, we have two groups that kind of pop out, or actually three groups. We have the children, age 0 to 4, adolescents, 15 to 19, and then the adults greater than 65 years. And these are the groups that are most likely to sustain a TBI. This has been changing over the years, but there's now quite a bit of literature on who's sustaining TBI, and so we know these figures are real. In the United States, from 2002 to 2006, there was an increase in fall-related traumatic brain injuries among the adults aged 65 and older. I like to think that that's because they're more active. So there's a 46% increase in the emergency room visits, a 34% increase in the hospitalizations, and a 27% increase in the traumatic brain injury related deaths. A recent Canadian study done out of Montreal showed a similar increase in fall-related TBIs among the elderly. So how does this impact an elder's health? Often this is the end of independent living. when they've suffered a head injury. They're especially vulnerable, suffering worse outcomes after TBI, greater tendency of home-related injuries, and they're more likely than younger adults to have the comorbidities, the susceptibility to complication, and complex health conditions, and a history of polypharmacy. So it's a very important issue in the elderly. They're more likely to suffer a subdural. Again, some of this is due to the fact that as you age, your brain shrinks a bit. They require more inpatient rehabilitation, a longer hospital stay, and of course that is partially because of the comorbidities. So recent estimates say 25 to 40% of the mild traumatic brain injury patients experience long-term complications beyond the expected 3 months. When I first started in this field, they were basically saying everybody gets better. And then we started to say, oh no, maybe a few people don't get better. And now it's as high as 40%. Some people who are presenting at the International Brain Injury meetings in San Francisco had studies showing that in certain populations it could be as high as 40% do not get complete recovery. The kinds of things that you see are declines in mood, psychosocial functioning, decline, and cognitive and incomplete recovery compared to the younger population. And this was Feinstein's work, and he and I did a lot of work together. There's also an increased risk of subsequent TBI. So you have one, your balance is impaired, your cognition is impaired, and you're prone to a second fall. So many of the individuals who do suffer this, they live well into older age, like 65 is not old anymore. You can live another 20 years, and they're often carrying a disability because of the head injury. Unfortunately, it's difficult to diagnose brain injury, and any of you working in this field will certainly be familiar with that problem. There are no specific blood tests. We've been looking for blood markers for a long time. That's going on right across the world, and nobody's come up with a workable blood marker. We've seen some blood markers, but they have to be drawn within 3 hours, and again, it's not even 100% capture. So we don't have any of the nice tests that many others have. The elders offer additional limitations in assessing severity of traumatic brain injury. They may already have altered cognitive function from medications and from comorbid disease. Are you hearing us well? Okay, we have to assume you are. The quality of life research. And I'm going to turn this over to Cindy, because she has done a lot of this work and is very familiar with it, and I want you to hear from her. So here's Dr. Cindy Hunt.
Hello and welcome. And so what we wanted to find out is that we've looked at the literature, and certainly previously in terms of the clinician rating and how people were recovering was basically based on the clinician. So it's basically fairly new within rehab medicine that people are looking at what was coined the insider's perspective. So clearly some of the work we're doing here at St. Mike's are building common data elements for traumatic brain injury, and we felt a critical variable to look at was quality of life. So that was one of the drivers towards our question of what are the current tools that are out there to examine elderly populations around that. And there was no clear evidence, there was no systematic review, so that certainly gave us this great opportunity to delve into this question. So in terms of our objectives, we wanted to see what is the scope of the measurement tools. We wanted to know about the characteristics of the measures. We wanted to know how they were measured, at what points in time. And we wanted to know, as Donna pointed out earlier, were they at different kinds of severity, mild, moderate, severe? And the other question is, do people use multiple measures, and what are the combinations that they tend to use in these multiple measures of quality of life? So let's look at the inclusion and exclusion criteria. As we mentioned, we followed the PRISMA guidelines. And starting off obviously seems pretty obvious that we want to get participants that are over 65, but that's not as easy as you think. Some of the studies were actually longitudinal, and they might have been, the patient might have been injured in their 40s, and you had to dig a little bit deeper to find out, in fact, these questions were asked over time, so they did get to be 65. So there was more work entailed than we thought in looking in that criteria. Clearly, the quality of life measures, the literature supports that really we will always want to have more than one domain in what's being measured. We wanted to make sure that this is how we validated our quality of life measures, that we could at least identify one additional article that used that quality of life measure. And there were studies that included different types of patients, maybe a more acquired brain injury. And so we were fine to include those as long as the TBI patients had separate outcome measures, and we could make some conclusions based on that. So the exclusion criteria followed along those lines. So here is our PRISMA map of the articles that we identified. So we really had over 3,000 to begin with. We found duplicate studies that were up to 15, and then we narrowed it down based on our inclusion and exclusion criteria, so that we came to a total of 72 papers. When we did our data extraction, we actually identified one of the papers had included 2 studies. So it gets a little confusing here. We have 72 papers, but 73 studies. And so we built an Excel spreadsheet, and these were the items that we extracted: the genders, the number of population, injury severity, the mean age, and so on. And so now I'm going to tell you some of the results that we came across on when we did our final review. And so the majority of studies were cross-sectional. Some were cohort, a limited number were case control, and a limited number were randomized controlled trials. And so the point of including this graph is just to give you some highlights. We actually have submitted this paper for publication, and so I just wanted to give you a snapshot of some of the tables that we have had presented in this paper. So this table basically is telling us about the characteristics of the studies. We identified that when we talk about actually where the settings were, only 6%, actually only 4 papers were Canadian. Most of them, 46%, were from the US. We know that the age range of the population was actually quite variable. Some of the studies were actually from age 12 to age 93. But the mean age identified at time of injury for these studies were 20 to 39 years old. There was a large number of males in most of these studies. One of the studies actually had 100% males, and actually the one that had the least amount of males were actually 47%. So now I want to talk a little bit about how elders or seniors were represented in the studies. And in fact, this is quite a significant finding in that we did actually find no specific study that just looked at adults who are 65 years and older exclusively. And in fact, we only found 15% or 11 of the 73 studies reported that the exact number or the percent of seniors in the study, so that if they at least reported the percent and we had the total, then we could actually figure out the exact number of seniors. So just very few. That's a highlight right there. Then we found other studies reported an age range, but they did not give us the exact number of people who were 65 and over. And you can see this was a large proportion of the studies, almost 70%. And then 10% of the studies actually used very unconventional definitions of a senior. Some were 40, 45, or even included 55 years and up. So just to make a few highlight comments about the dimensions that were included in the quality of life, this was again a little certainly eye-opening that within these 73 studies there were actually a wide swath of 27 different multidimensional quality of life measures. So clearly our question of which one will we choose didn't become any easier when we got to this part. So what I've listed here is the domains, or the different kinds of dimensions that the variety of tools looked at. So again, you can see there's quite a large swath of issues, from philosophy of life, standard of living, creativity, happiness, in terms of social isolation, sexual functioning, down to safety and their motivation. So the point of this table was to talk more about the exact, give the reader more information about the qualities of these measures, looking at quality of life in populations with traumatic brain injury. And so here we've talked about, even in terms of the number of dimensions, and some of these tools, the dimensions range from 2 dimensions to up to 17. And then we can talk about the number of items, and this is important if you're a researcher trying to figure out, how long is this survey going to take people. Some of the measurements actually had items that were 12, and that was the SF12, 12 items. But the Bigelow Quality of Life Questionnaire actually had 263 items. Also of note from this table, and other issues to mention, are that we actually identified, of the 27 tools, 24 of these tools were generic tools. So really they could be used for measuring any kind of illness or disease within the elderly, whereas 3 of the tools that we were able to identify were TBI, or disease specific. These tools are Belt's tool and the Quality of Life tool, and another one, the LAT tool. So the next, this slide is really just to give an overview of what seems to be used the most. So really the frequency of studies that are that we used in this review, and which quality of life measure was used the most. So it's easy to see that the SF36 and the SF12 were predominant. Interesting, those do cost money to implement those tools. We have the sickness impact profile was also a lead, as well as the EuroQOL and the WHO one, and the QOL Libre, which is the QOL Libre is the one that's disease specific. Okay, next. Oh, lost it. I don't know where this slide is there. I'm just going to push to the next one. Okay, there we are. So this particular slide again is there's a table in our paper that mentions the different kinds of tools that are used and lists the authors. And the point that I'm trying to make here is that we also looked at different kinds of TBI. So if you look at the bottom line of the table, we have a grand total of all the study participants. And this was of interest to us in terms of looking at future work that could be done. That when you actually add up all of the moderate, severe, and the populations were much less than the populations of mild. So clearly there's more work could be done within the mild TBI or concussed population. The next table, so I'm going to have to push this again. So this table again is just more of a summary of the previous one. I think what I really wanted to mention, there is another table that speaks more about the parameters of assessment. So when the tool was actually implemented, the timeline, so that could have been 1 to 3 months post-injury. These were the intervals that were commonly used, or 3 to 6 months post-injury, 6 to 12 months, 1 to 3 years, 3 to 5, and over 5 years. So it's interesting to see how these tools have been used in terms of the time frame, and then the methods that they were used. Most of them were self-reported, but others were actually used on telephone and mailed surveys. One of our objectives was to look at how many studies used multiple measures of quality of life. And we actually found that 20% used more than 1 dimension. And so some of these used up to 3 measures, others used 4, 1 used 4, and all of the combinations, so that a very common one was with the SF36 or the SF12. We have a table that identifies the author and then the tools, the quality of life measurement tools that were used in combination. So we certainly recognized there were a number of limitations within our review. One of the things we did do was actually, I wanted to mention that we did conduct a quality assessment, and that we were able to do, it was difficult to figure out which ones we would do these quality assessments on, because I mentioned earlier there were 73 studies, so that's quite a large number to do the quality assessment on. So we decided to look at the 11 studies, or the 15% that we were clear that we truly knew the number of seniors that were there. And so for doing that quality assessment, we used the Downs and Black assessment tool. And out of a potential score of 18, the 11 studies that we reviewed scored on average 15. So they were good quality studies. So in terms of general limitations, we certainly looked, we always have the publication bias. We only looked at English studies. And the second point to be made here is what Donna alluded to earlier. There's certainly challenges in measuring TBI to begin with, in terms of different kinds of injuries, different kinds of causes, different course of injury, and even the time since injury can make a huge impact, obviously, on how people are reporting their quality of life. We know that the differing definitions of seniors was quite a surprise. We didn't expect that there would be that much diversity, so that's something of interest. I know Donna speaks to clinically, you know, that people can be aging earlier if they actually have a TBI earlier in their lives as well. So that could be one of the reasons why authors are including younger age groups as seniors. For the other limitation of the review, there could be bias in the study population. Some of the populations were community-based, and those who are doing well obviously are living in the community. Those are going to be in other types of institutions. So those are some of the highlights of the limitations. Certainly our overall conclusions, that we really felt it was difficult to make inferences on the quality of life, because the majority, the largest proportion of the populations in each of these individual studies were clearly not seniors. So in order to extrapolate those findings to a smaller proportion of elderly was challenging. So it seemed to us that that investigators may not be accounting for what are the specific experiences that an elderly may have. And that could be when we looked at, we came to that conclusion by looking at what are the dimensions that are engaged in the measure itself. So it certainly would be worthwhile, and these were some comments from our patient, that not all the dimensions in some of these tools that she felt would be something an elderly would be able to comment on. So there could be some dimensions around quality of life that most of these measurement tools don't even tap into, that are most applicable to the elderly. So opportunities for new measures to be introduced. There's clearly, as I mentioned earlier, a large underrepresentation of elder females. That seems to be, there certainly seems to be some gender differences in the occurrence of injuries, but we really don't know that much about elderly females because they're clearly underreported within the literature. I think another conclusion that is of interest to note, and many of you have done work in quality of life, I'm sure aware of this, certainly seems to be recommended that if you're studying quality of life, you might actually want to choose two measures. One would be more a disease-specific measure, as well as a generic measure, so that you have the opportunity to compare your outcomes with other diseases, perhaps for cancer or for AIDS, or to make some other general comparisons in terms of quality of life for the population that you're studying. But you also have the disease-specific quality of life measurement to make comments on as well. We did want to share what were some of the outputs that we've had to date. We just started out saying we were looking for some of the what would be a common data elements to include on our database here, and we actually have chosen the EQ5D. That was one of the popular ones. But we've actually subsequently recently found out there is a fee for that. So we have now chosen to go to kind of further down the ranking of what's used, but the WHO brief. And so those are, we're just trialing and piloting that with our patient population. So part of the work that we're doing is helping to develop common data elements for the rest of the province in TBI. So this recommendation of using the WHO brief has been accepted by that group. We've had an opportunity to present this information through the poster through the Canadian Association of Gerontology, and as I said, we have our manuscript in review at present. So we'll look forward to questions that you might have, and Donna is here to also make additional comments.
No, one thing that I was neglectful, I didn't give you Cindy's background, because Cindy started as an outpost nurse, canoeing in to see people. Then she became, after a few years, became director of a nursing school. She did a PhD at Johns Hopkins and a fellowship at Johns Hopkins, and she's now appointed at University of New Brunswick and at University of Toronto. Okay, open for questions.
Okay, thanks, Donna and Cindy. That was an excellent presentation. We don't have a lot of questions yet, so please continue to submit more questions, but we have some to start with. So my first question is TBI a homogeneous injury?
No, that's it's very, very diverse, the causes of TBI. Even the definition of TBI is not clear. Some people are including stroke under TBI or ABI. So it's very, very homogeneous, the causes, heterogeneous of the causes of traumatic brain injury. We see a lot of people now that are having falls, just out walking in their homes. We see a lot of people who are engaged in sports. We're now seeing the elderly skiing much longer. As many of you who ski will know that it used to be you could ski free after 65. Now a lot of centers you have to be 75 to get free skiing. So it's great the way the elderly are getting more into these things, but of course that means we're going to see more of the falls.
Okay. Is a single question about the quality of life good enough for clinical care or research in most cases?
Cindy's going to answer that one.
And so that actually was an interesting question. We started off that was one of our inclusion criteria, that we did want to have multiple dimensions that were measured, and that was from the literature just in general on quality of life. So we stuck to that, but it was surprising the number of articles that we did exclude because they simply had one question around quality of life. So I think certainly would be interested to hear other people's thoughts on that. It's if you have a lengthy questionnaire, it's always nice to have something that's smaller, but I think in terms of the quality of the information that you want to get, it's always useful to have more dimensions that would be than just a one question quality of life measure.
Okay. Here's another question. A lot of tools reported are general tools. Do you think there is a need to develop tools specifically for the elderly?
Yes, I definitely would agree to that, and I know our patient who was part of the team, she would agree to that as well. And so I think that's a whole area that I would love to look at more, would be actually the qualitative literature that looks at quality of life in the elderly. I'm sure that would be a stepping stone to begin to understand what is important to elderly, what are sort of the key features, and obviously, you know, different disease entities might have things that are more prominent than others, but I think starting to look at the qualitative literature might be a good place to begin. But I agree that there would definitely be opportunities to look for new instruments or develop new instruments and test those with elderly.
I just want to weigh in on that a little. I totally agree with Cindy, and I think some of the work that we did, we found that the outcome measures are measuring things that the elderly don't necessarily engage in. For example, return to work. and you know, some of the home activities. So I think a specific measure for the elderly is definitely needed.
And I think too, the other piece you want to be sensitive to would be the gender differences. So, you know, certainly quality of life issues might vary on gender. That didn't seem to be something that came out in the literature, but we certainly know the injuries vary by gender. So I would think that would be definitely something when you're exploring a new measure to consider as well.
Okay. Why do you think there has been such little study in older patients who are one of the largest groups with head injuries?
Well, I'm going to start with that one. I think, first of all, a lot of us in the field think that the literature in head injury is not good, period. And secondly, I think that all of the focus on head injury of late has been on sports-related head injury, when in fact that's only about 20% of head injuries or less are sport-related. So I think it's been, you know, what's popular, what sells, and I think seniors haven't sold up till now, but I think it's a huge group that needs to be addressed, and we're very grateful to TVN that they are addressing this group.
If I could add too, sorry, we're just hearing some feedback on our mics. I hope it's everybody else is okay. But the point I wanted to raise was that some of these injuries might be missed. The head injuries might be missed because the orthopedic injury might be taking precedent. It's easier to see, whereas the traumatic brain injury is that is more silent or invisible injury.
Yeah, I think that's a huge one that with other injuries, there's no question that if we look at the etiology of head injury and the incidence of head injury, so much is missed because if you come in with other injuries, that's listed and the head injury often isn't captured.
Okay. Outside of dissemination, what do you think the subsequent research opportunities arising from this knowledge synthesis? The subsequent research opportunities.
Well, I think you said outside of dissemination. Well, I think subsequent studies will lead us into which groups are particularly at high risk in the elderly, and that will define our rehabilitation and where we place our funding. For example, there was a wonderful program that was going on in Ottawa for the frail elderly, and it was, they had identified that the frail in the system, elderly women were the bed blockers. So they introduced this program to make sure that after fractured hips, for example, that the elderly received a huge program, and they found this was very helpful in keeping them in their home. So I think, again, if we're looking specifically at traumatic brain injury, if we could identify what is the most disabling part of that injury, then we can bring specific services to that part, and we can hope to maintain the elderly in the community longer following a TBI.
And I'd also add, I think the other big piece is putting the patient first, which is part of the mandate within Ontario, is that this is very important clinical information. We know we have all these other outcome measures that we're looking at, but the quality of life measures are what matters to the patient. So if we can see, and certainly within the clinic, if we can see people really low quality of life, and now over time, if the treatment or the management or the advice that they're getting from the nurse or the clinician is helpful, then we can see that in terms of the success of the intervention, and it helps the reason that they need to be discharged or managed with family practice. I hope that's helpful. I know we're hearing a lot of feedback here at this end.
Oh, you are hearing feedback. We do have construction going on outside our window today, so that might be it.
Okay.
hopefully. I have another interesting question and hope that you're able to answer this. Could you speak to the possible link between dementia and TBI? Somebody has the understanding that there might be a link that's been discussed recently?
Well, that has been researched in depth, and initially the research was coming out and saying there wasn't a link. But more recent research is, and I think this research makes a lot more sense, having looked at thousands of people. I think that, you know, if you have a cognitive problem and then you age, and we're expecting cognitive problems in the elderly, and so a cognitive problem on top of a cognitive problem is definitely going to give increased cognitive problems, which is another word for that is dementia. So I think that repeated head injuries will definitely lead to earlier dementia. Will one head injury lead to earlier dementia? That's an issue that is being struggled with internationally. And people are looking at many factors. They're saying, you know, if we look at sports, for example, why did Wayne Gretzky never have any problems when other people will have less concussions and have problems? They even know cases where they have profound problems and they've never lost consciousness or never had a documented concussion. So the things that are being looked at internationally is there a protective factor? Is there something in the person's immune makeup? So it's a very complicated answer. I think the simple answer is yes, having repeated concussions will lead to earlier dementia. The complicated answer is it depends on your genetic and your genetic makeup and your DNA as to the number that will make you prone to dementia at an earlier stage.
Very interesting. Okay, I have two more questions. So the next one is, if you have one key message for gerontologists regarding their management of older people with TBI, what is it?
I think both Cindy and I would say this, and the key message is listen to the patient, treat the symptoms. You know, we went through that phase of where everyone should just be put at rest and do nothing. And hopefully, I think we've pretty much come out of that phase. So listen to the patient, treat the symptoms, provide reassurance, and provide what they say they need. So if you're hearing that they're at home alone and they're falling a lot, then you need to provide backup for that. So I think one of our key messages would be listen to the patient and direct treatment according to the patient's needs.
Yeah, I think I would, just to add to that is really it's the insider's perspective. So what is it that's meaningful to the patient that they want to, where do they want to reach so that they are feeling back to where their quality of life is where they want it to be.
And again, we can't be too strong on treating the symptoms because, for example, dizziness following traumatic brain injury. And, you know, I had a lady come in recently who was 85, and she'd been looking after an adult grandson at home, running the home, doing everything, and she had profound dizziness, benign positional vertigo. We did cantaloupe repositioning, and within 2 weeks, the dizziness was gone, and she was back running the house again. Management of symptoms is key.
That's good. Okay, I have one last question before we go back to John for final remarks. What are the next steps that can inform how older people receive rehabilitation or community care?
Well, that's a tough question. We're engaged right now in an Ontario Concussion Initiative. We think that our present system is bad. We don't think that people can be managed in sports clinics and tertiary care clinics alone. So our initiative is attacking how they're handled in emergency, and we've had great success with our new approach at St. Michael's. And we're attacking family physicians and trying to give them tools, and we're that way we're trying to have less reliance on these tertiary care clinics where treatment you're waiting up to 9 months. So I think a coordinated approach across Ontario is what's needed, and that's what we're engaged in right now.
Wonderful. John, back to you.
Okay. Well, I'd like to thank our presenters, Donna and Cindy, for the excellent presentation and great discussion afterwards. And the questions were very insightful. And if there's other ones, please forward them to us, and we'll try to answer them offline. The webinar slides will be available on our website within the next couple of days, as are all the other webinar slides from all the webinars that we've done. And as we go along, this is going to become an increasingly rich resource of material and presentations. So please visit our website and review the websites and please feel free to refer other people to the website. Just from a process point of view, a brief survey will pop up on your screen within the next few seconds. Your responses are very useful to us, and please provide some feedback as to how we can improve the webinar series. Things like construction outside our window are outside our control, but the things that are within our control, we'll do our best to improve them. And please refer the webinar details to other people that may be interested. The more people that we get participating, the better. We have two upcoming webinars. One is on October 21st, which is a systematic review and meta-analysis of end-of-life decision-making tools and strategies. This is another knowledge synthesis project, and the presenter there will be John Yu, who's a principal investigator for that project. The next one after that will be on communication technologies for engaging patients, families, and caregivers in the healthcare system. That's a scoping review, and that's by Anthony Lombardo of the University of Toronto. Please follow us on Twitter. And that's our hashtag there. So again, I'd like to thank our presenters, Donna Ouchterlony and Cindy Hunt, for the excellent presentation, and look forward to speaking with you at our next webinar, which is on October 21st, 2015. So with that, we'll finish the webinar.